Well, hello and welcome to the IPDLN 2020 session on maternal and child health. So my name's Ruth Gilbert. I'm speaking to you from University College London in lockdown London. And we're going to have 4 speakers today of 10 minutes each, and then we'll have a 15-minute discussion. So I look forward to your questions. You can send them in during the presentations on the Q&A or afterwards. So we're going to go now to Professor Astrid Guttmann, who is Professor of Health Policy and Public Health at the University of Toronto. Astrid's going to tell us about demonstrating opioid use using administrative data in pregnancy. Thank you, Astrid.
Thanks, Ruth. Can you see my slides?
Not yet.
Okay. After all that, here we go. Can you see them now?
Not quite, but they're coming. There we are.
Okay, perfect. I'll put my timer on. Hello, everybody. This is seems a little weird to be speaking into the screen, and I wish we were all in Adelaide together. So I'm delighted, though, to be presenting on our work on identifying prenatal opioid exposure in using health administrative data in Ontario, Canada, and just acknowledge the team, and in particular, Andy Camden, whose doctoral work this represents. Oh, sorry, I don't seem to be able to move them. There we go. So just by way of background, as many of you know, a number of countries, including Canada, would consider themselves to be in the middle of an opioid epidemic. And there's been many studies from multiple jurisdictions documenting the increase in pregnancies affected by opioid use over the last 10 to 15 years. And of course, population-based surveillance and research are really key components to improving care for women and their children affected by prenatal opioid exposure. And health administrative data are a very attractive source of data, both for surveillance and for research. But they vary across jurisdictions, and a number of different methods have been used in the literature to define prenatal opioids. So one obvious example would be a number of jurisdictions have prescription databases, although not always whole population ones, often only for those on social assistance. And that's one source of data. Another source of data have been newborn records. So some newborns who are exposed to opioids prenatally manifest something called neonatal abstinence syndrome, which is a withdrawal syndrome that needs to be treated at birth. And this has been another way in which prenatal opioid exposure has been defined in the literature. And then other studies have used healthcare use for opioid use disorder, either from the delivery record or for jurisdictions that can also link across time for other healthcare use during pregnancy. But each of these methods may represent, or the ascertainment of populations may be quite different. And there are important issues of generalizability depending on the method used. And so our study was, the objectives were to estimate differences in the ascertainment of births with prenatal opioid exposure by different methods that have been used, and then to describe and compare maternal characteristics by each of these ascertainment methods. And so this was a study done at ICES, which many of you are familiar with, is an institute that has a legal designation in Ontario to hold administrative health and demographic data for purposes of research. And so we studied a cohort of hospital births from 2014 to 17 in women 12 to 15 who were all eligible for provincial health insurance. And apart from the delivery records, we also linked to healthcare records in pregnancy, as well as a baseline period 2 years prior to pregnancy for women. And then as well, I'll draw your attention we are able to link the maternal delivery records to the infant birth records. Number of different health data sets, and I'll just also highlight that we recently, starting mid-2012, Ontario now collects all prescription opioids that are dispensed. So this is now a population-based data set. And essentially what we did was we looked at a number of different methods of defining prenatal opioid use. We compared the positive percent agreement with 95% confidence intervals across a number of conventionally used definitions versus a comprehensive method enabled by, as I've described, the linkage of both delivery records of mothers to their infants, as well as linkage to opioid prescriptions during pregnancy and healthcare use throughout pregnancy, as well as in a baseline period. And then we estimated the additional cases identified with the comprehensive method and examined and compared maternal characteristics across these definitions. A couple of just really small little notes. We did define prenatal opioid, at least for analgesic use, as clinically significant. So we only included those where the prescriptions were for more than a 10-day duration. And then we also excluded iatrogenic neonatal abstinence syndrome. In other words, infants who are given opioids after birth for a range of reasons who may then also have withdrawal. So using all three data sources, we identified over 9,600 pregnancies affected by opioid use out of over 450,000, so about 2.1%. And as you can see in this diagram, the majority were ascertained with the prescription database, so not surprisingly, for percent agreement of 79%. The next largest group were those with a newborn record with neonatal abstinence, and then a smaller group were ascertained by maternal-related opioid hospital records in pregnancy or at the time of delivery. And so this slide just shows the number of cases from our cohort, that would be the difference in cases based on how others have defined prenatal opioid use. So in some studies, prenatal opioid use is only ascertained by the delivery hospitalization. So in many jurisdictions, those are the only hospital records that are available, or there's not the ability to link the mother's records across pregnancy. So you can see that, out of the, over 9,000 cases, over 8,000 of them would have been missed if you only used a diagnosis of opioid use disorder at the delivery hospitalization, a few more if you were able to include pregnancy as well. And then the numbers, get a little bit smaller in terms of those that you miss if you only have neonatal records. And then these are just based on how opioid use, is described. So some studies have excluded opiate maintenance therapy from the analgesic records, et cetera. Just to comment a little bit on maternal characteristics. So these are, this is just comparing characteristics of all mothers with any indication of prenatal opioid use. So this is the 96,000 mothers here, and not surprisingly, characteristics, show much lower socioeconomic status. So almost 40%, or just over 40%, live in a low income neighborhood as compared to 20% of other mothers. Very high rates of social assistance use, high rates of medical comorbidities, as well as severe mental health and addictions problems as ascertained by the need for hospitalization or ED care in preconception. But then to look at it more carefully by the ascertainment method here as well, you can see, significant differences in the characteristics of women based on the definition, the ascertainment method for prenatal opioid use. So this is the comprehensive method here, this column, prenatal prescription opioid data versus using hospital records of the mother or the newborn record, including neonatal abstinence syndrome. And you can definitely see, much higher proportions of women with mental health and addiction, the need for acute care for this in those where the prenatal opioid use was ascertained from the maternal records or from the newborn record. Similarly, even a higher proportion than overall of those who live in low-income neighborhoods. And then here, one indicator, which is that the infant ends up either temporarily or permanently being removed from the mother's care at birth. So much higher rates in, mothers whose prenatal opioid use was not from the prescription, not because of prescription use, but because of healthcare use for opioid use, or from the newborn record indicating neonatal abstinence syndrome. So clearly, one gets a much more comprehensive estimate with the ability to link both maternal and infant records, as well as linking records across time and across sectors. So with prescription data, we showed that, compared to other studies that have more limited ability to ascertain comprehensively, quite a range of difference in cases that are ascertained. These methods clearly are selecting different populations. And so depending on the data that's used, the research question should guide the construct of interest. We really did this just to sort of help researchers, especially in jurisdictions where they don't have comprehensive data, think a little bit about and contextualize, some of the kinds of cohorts that would be constructed using their data. And then, of course, this, I'm speaking to the converted, but of course, many limitations, even with comprehensive health administrative data, certainly around, our ability to pick up illicit use, and, that we don't really have a gold standard with which to compare these data. So in summary,
Astrid, I'm going to have to stop you there because we need to move on to the next one. Thank you very much. So the next talk is going to be given by Julianne Sanguins and Marni Brownell. It's a double act, and they're going to be talking about the Manitoba Healthy Baby prenatal benefit. So Marni Brownell is from the University of Manitoba, and she's a professor in community health sciences, and Julianne Sanguins is a research program manager from Manitoba Metis Federation. Over to you. I think, Julianne, you're speaking first. Thank you.
Thank you, and I'd like to welcome you virtually today to the homeland of the Métis people and Treaty 1 territory. The Métis and the First Nations people are two of the Indigenous peoples acknowledged in our Canadian Constitution. And Marni and I will be presenting today. And there's traditional. We're going to be talking about the Strength Project, which is supporting resilience in Indigenous child health and development. This is a partnership project between the Manitoba Métis Federation and the Manitoba Centre for Health Policy. The Manitoba Centre for Health Policy also worked with the First Nations group here in Manitoba, but today we're just going to be talking about the Métis results. We looked at 5 programs under this umbrella study. We looked at the Healthy Baby Prenatal Benefit, which is what we will be speaking about today, Families First Home Visiting, Full Day Kindergarten, Roots of Empathy, and Boys and Girls Clubs of Winnipeg. And you may have heard some of these other presentations during this conference because they're threaded throughout. In Manitoba, the Healthy Baby Prenatal Benefit Program is eligible for women who are pregnant and it starts in the second trimester of their pregnancy. They want to promote healthy pregnancies and births in women. It is a magnificent amount of money, up to $81.41 a month that the women receive. And to be eligible for it, they have to have a medical note that confirms their pregnancy and the expected date of confinement, complete the application form, and their family income has to be under $32,000. They also have to be a resident of Manitoba.
Thanks, Julianne. So this study was conducted at the Manitoba Centre for Health Policy using the Manitoba Population Research Data Repository, which, like Astrid explained for ICES, is really a collection of data sets. We've got almost 100 different data sets in the repository, and they go across several different sectors. Many of them are for the whole population, and most can be linked at the individual level. So some of the data sets that we used for this study, of course, we needed Healthy Baby Prenatal Benefit Program data. We needed hospital birth records. And as Astrid talked about for her study, we also have a mom-baby link that allowed us to link the moms who had received the benefit to their baby's birth outcomes. We used the early development instrument because we followed these kids all the way to kindergarten. And we also used the Manitoba Métis Federation registry to identify which of the moms were Métis. So one of the challenges of this type of evaluation is that it's done after the fact. So we can't randomly assign women to receive the prenatal benefit or not receive the benefit. And we couldn't also just compare Métis women who had received the benefit to Métis women who didn't, because we know that low-income women who are eligible for the program also have a greater likelihood of having poor outcomes, which is why the program was developed in the first place. So we used the data in the repository to include only Métis women who received income assistance during pregnancy, because we knew they were all very low income. This allowed us to make sure they had the same very low income, and they were all eligible for the Healthy Baby Prenatal Benefit. We studied this over we had 8 years of data to study this. And not all those women who received income assistance and were eligible for the prenatal benefit applied for and received it. So you can see the numbers there, just under 4,000 for those who did get the prenatal benefit and just over 1,000 who didn't. Recognizing there may be other differences between these women, we used some of the data we had, particularly from the newborn risk screen, which provides information about things like whether mom smoked during pregnancy or drank or used drugs during pregnancy, whether she was a single parent, her education level, all sorts of characteristics that allowed us to balance differences between those who received and those who didn't. We use propensity scores and inverse probability of treatment weights to do this balancing. And recognizing that this balances things we can measure, but there may be things that we can't measure that make a difference. We conducted a gamma sensitivity analysis, which allowed us to see how sensitive or robust our findings were to unmeasured confounding. Using our repository of data, we were able to look at a whole bunch of outcomes that we thought might be related to the receipt of the prenatal benefit, including birth weight, large and small for gestational age, preterm birth, APGAR scores, and whether breastfeeding was initiated in the hospital. We looked a little further out to see whether the infant was readmitted within 30 days of birth or had a hospital admission anytime in the first 2 years of life. We followed the kids and looked whether they had their full first and second year immunizations. And as I mentioned before, we followed them all the way to kindergarten to look at their early childhood development scores using the early development instrument. Our results in terms of what was associated with the prenatal benefit, this is showing relative risks. Anything down here represents a decrease associated with the prenatal benefit, and this represents increases. And of course, when the whiskers overlap the number 1 there. It's not statistically significant. I've bolded the results that were significant. So we've got a decrease in low birth weight birth and preterm births, and increases in large for gestational age, complete immunization at 1 year of age, and complete immunization at 2 years of age. I faded this one out because when we did the gamma sensitivity analysis, this was not robust to unmeasured confounding. A little further out, here are the hospital readmissions, whether it's 28 days after birth or in the first 2 years of life, and then along the 5 domains of the early development instrument and vulnerable in 1 or more domains. None of these are statistically significant except for the readmission within 28 days. And we found that it wasn't sensitive to unmeasured confounding. So meaning that we really don't want to hang our hat on that result. And I'll pass it back to Julianne.
So thinking about our study, receipt of the unconditional income supplement during pregnancy for the Métis women resulted in a reduction in low birth weights, which we would like to see, reduction in preterm births, again, a positive outcome, and an increase in immunization rates at 2 years of age, and sort of at 1 year, but that wasn't robust enough. Questionable ones are the increase in large for gestational age and why that might be, the fact that there was no difference in early childhood development domains. That's another area that needs further study. And finally, we were wondering what supports do we need to have in place either through the Manitoba Métis Federation or other policy areas to ensure that all women who are eligible for it apply for the Healthy Baby Prenatal Benefit, especially given that we have these good outcomes. We'd like to acknowledge the commitment of our MMF president and cabinet, our elders and our youth who are the knowledge keepers of our past and present and our future. I'd also like to acknowledge our veterans who have served us in the past and continue to serve us as it is Remembrance Day, our funder, Métis citizens in Manitoba who allow us to serve them in our vision of a well-Métis community. And of course, a work like this is never done independently. And so we have a whole team of people that worked with us who are all listed below. And this is comprised of people from the Manitoba Centre for Health Policy, students, as well as the Manitoba Métis Federation. And I'd like to thank you for your kind attention today. And I'm sure you'll have questions, especially for Marni when we get to that time of our time together today.
Thank you very much, Julianne and Marni. That was fantastic, and you kept to time. Thank you. So we're now going to move on to Dr. Louis Chislett, who's from the University of Glasgow, from the Social Science Department there. And Louis is going to speak about predicting childhood overweight using linked administrative data and the implications for targeting early years interventions. So over to you, Louis.
Yeah, thanks a lot. So yeah, this study was conducted at the MRC Social and Public Health Sciences Unit, which is part of the University of Glasgow. So I've called it Predicting Childhood Overweight in Linked Administrative Data. And specifically, I'm thinking about whether there's any lessons for interventions on overweight in young children. So briefly, I'll speak about what that means. If my slides will move on, which it doesn't seem like they are. Okay, I'll just stop sharing really quickly and open up the slides again. So yeah, as I was saying, we're thinking about interventions, in particular with interventions on overweight or obesity in young childhood. We're thinking about preventative measures prior to that health outcome developing. And so if we're thinking about targeting interventions, what we really want to think about is can we accurately identify or predict which groups of children based on certain characteristics might develop overweight or obesity? And we're specifically thinking about at age 4 to 5 years old, which is when children start school in Scotland. And so a bit about the sort of current evidence or current approach that people take. So normally what studies tend to do is they tend to combine a number of different variables collected in early childhood into mainly logistic regression models, and then they'll predict overweight at 5 years based on these variables. And they tend to have a sort of moderate accuracy of those prediction models. That tends to be the case in most studies. So what we're looking at is, can we apply that to administrative data in Scotland? And we also looked at some machine learning models to see if they might offer some improvement. One of the reasons we wanted to do it on our particular data set, which I'll get to, is because a lot of studies use survey data, and these might not be representative of the population as a whole. And so our aim sort of forms 3 points. So first of all, can childhood overweight be accurately predicted using individual screening variables? Secondly, then, can we combine these screening variables into our models to improve our prediction? And then can we look at the results of these models to inform us one way or the other as to what sorts of interventions might be useful, and do any particular outperform the others? So our data set was a Scotland-wide administrative cohort. So it was based on children born between September 2009 and February 2013. And I've given a list of some of the data sets that it links there, but essentially they were either hospitalization data sets, or they were birth-related data sets, i.e. variables collected at birth, like birth weight, or they were then data sets that were collected during childhood by health visitors. And they were linked by what's called the Community Health Index. So there are about 120,000 children in the overall linked data set. As you can imagine, with linking administrative records, there was a hefty amount of missing data. So actually our study population was around 22,000. And our outcome variable was a binary variable on overweight or obesity. So either a child was overweight at 4 to 5 years old, or they weren't. And that was using the IOTF cutoffs. And so I've given a big list of some of the screening variables we considered there. Essentially, a screening variable essentially is just a variable collected early in childhood, which we've then had some kind of cutoff to make it binary. And these are generally based on literature as such. In general, they come in a few categories. So either they were socio-demographic, so that can be something like the level of deprivation of the family. Perhaps they were collected at birth, such as birth weight. Or they were collected over the child's early childhood, like their weight at a certain point in time, for example, 27 months. And so the study design followed the aims quite closely. So stage 1, analyze the predictive capability of the individual screening variables using things like sensitivity. Stage 2, then combine them into models. So we used 4 models, so logistic regression, decision trees, random forests, and gradient boosted trees, in order to predict that binary overweight variable, and then analyze the predictive capability of these models. And then stage 3, analyze the results, consider which models perform best, consider what evidence they were showing us. So first, I'll talk about those individual screening variables. So as were expected, they weren't very predictive at all. And that's really, I mean, to be expected. It's the whole point of the study is we're trying to combine these to see if they give us better prediction, but these individual screening variables weren't very predictive, other than a notable exception, which is the overweight variable at 27 to 30 months. That's essentially our health outcome at an earlier point in time. So that had a sensitivity of about 53%, positive predictive value of about 51% in predicting overweight at that later stage of 4 to 5 years. And then combining them into models. So we were analyzing the predictive capability of our models using ROC curves. And essentially with the ROC curves, for those that might have forgotten, it's essentially we look at the area under those curves that tends to fall between 0.5 and 1. So a really good model would have an area under 1, 0.5. So our logistic regression was by far the best performing model. So it had an area under the curve of 0.81. In comparison to the 3 sort of data science approach or machine learning models, their areas under the curve tended to fall between 0.7 and 0.75. So to put that into context, an area under the curve of 0.81 would be considered a fairly moderate to good model, whereas 0.7 would be fairly poor. We also fitted a logistic regression without the earlier measure of overweight, and that had a much poorer sort of predictive accuracy. So its area under the curve was just 0.64, which is considered fairly poor and verging on a fail. And so that there's clear evidence there that without using the earlier measure of overweight, there's much worse performance. And so I've just summed that up here. So individual predictors tended not to perform well in terms of their sensitivity, specificity, positive predictor value, with the exception of that overweight variable. And as I said, really that's to be expected. It's the reason that the study was conducted. When we then combined all those screening variables into models, overweight or obesity could be moderately well predicted or moderately to well predicted when using that earlier measure of overweight. But the machine learning models which we employed didn't actually improve that predictive accuracy at all, which was notable. And so what does that mean for intervention? Well, first of all, actually thinking about what those results mean. First of all, we can say, well, assuming that effective interventions exist, which isn't the point of the study, targeting might be used to close the health gap, but only among people who are already overweight. And that can be seen by the fact that we only got good prediction when we had an earlier measure of overweight in our models. Secondly, kind of leading on from that point, targeting preventative interventions doesn't seem plausible. And that's because we cannot accurately identify those most likely to benefit before they've developed the health outcome at an earlier point in time. And so therefore, in terms of prevention, it seems like a universal prevention approach is needed. And I'm not an expert in this, but I believe that's actually part of, sort of public health policy in Scotland. However, with all universal interventions, if we don't implement this quite thoughtfully, it might actually risk widening that health gap for a variety of reasons. For example, richer children may have an increased uptake of whatever interventions get implemented. And so leading on from that, upstream interventions, e.g. reducing child poverty or improving neighbourhood environments, which are things we should already be doing, seem like they might be effective, but obviously further study would be needed. And so quickly, I'll talk about the limitations. So administrative data sets like the one we use may not contain the best predictors of health outcomes. So clearly, there's a good reason why a lot of the other studies on this type of topic use survey data. It's because they can control which variables they collect. However, what variables might improve our prediction. Secondly, there could be a bias as a result of using our complete records data set. So we did perform some sensitivity analysis. We did some multiple imputation to try and correct for that. Our results were fairly similar after that. However, with such a large amount of missing data, it's hard to know whether your multiple imputation has had the desired effect. You don't know whether there's any missing, not random assumptions, for instance, that you can make that might affect how you impute. We want to run the same analysis on children that have already been intervened on for being overweight at an earlier point in time. I think that that's quite self-explanatory, really. When our models performed best was when they had an earlier measure. Therefore, why not look at children who have already had an intervention? It's also a further point of study to actually study the individual predictors or screening variables and see what effects each one are having on the outcome. So looking at things like odds ratios, for instance, from our logistic regression model might be appropriate. So yeah, I'll give some quick acknowledgements to all my colleagues at the Social and Public Health Sciences unit that I worked with and all the funding bodies given there. And I look forward to questions.
Thank you very much, Louis. Great and very, very good keeping to time. Thank you. So for the last talk, we're going to go back to Manitoba to Elizabeth Wall-Wieler, who's been who is a postdoctoral fellow in the Department of Pediatrics at Stanford University, but she's also at the University of Manitoba, and she's going to speak to us about maternal depression in early childhood and developmental vulnerability at school entry. So thank you, Elizabeth, over to you.
Thanks, Ruth. So yes, I recently finished my postdoc at Stanford and started my position as an assistant professor at the University of Manitoba. And I'll be talking about exposure to maternal depression and childhood developmental vulnerability at school entry. So before we get started on my talk, I'll just like to acknowledge my co-authors on this project, Dr. Leslie Bruce and Dr. Ian Gottlieb, as well as our funders and our data support from the Manitoba Center for Health Policy. So a little bit of background before I get started on my study. So it's well known that early childhood development is affected by a wide range of genetic, biological, social, and psychological factors, and that maternal mental health is an important factor affecting childhood development. Research has also shown that children whose mothers have high level of depressive symptoms have worse cognitive development than children whose mothers have few or no depressive symptoms. The studies that have been conducted around this relationship have often used surveys from a small number of mother-child pairs, have looked at single measures of childhood development, and rarely look at different periods of exposure to maternal depression. So in order to address some of the limitations of the research that currently exists, we wanted to assess whether the relationship between just to assess the relationship between exposure to maternal depression before age 5 and 5 different domains of developmental vulnerability at school entry, looking at exposure at any age and then also exposure by age of the child. To do this research, we used the data from Manitoba for all children who had completed the early development instrument from 2005 to 2016, resulting in just over 50,000 mother-child pairs. We measured maternal depression using physician visits, hospitalizations, and pharmaceutical data. So here we looked at maternal depression at any time between the child's birth and their 5th birthday, and then at every single age, 1-year intervals in that time period. And then developmental vulnerability was assessed using the EDI, looking at a composite measure of one or more vulnerability on one or more domains and vulnerability on the specific domains of development. We looked at the relationship between exposure to maternal depression and developmental vulnerability using log binomial regression models. And we adjusted for a series of maternal and child characteristics at birth and in pregnancy. So we did 3 different analyses. The first analysis, we looked at a full population and then looking at the relationship between exposure to maternal depression at any time between the child's birth and their 5th birthday and developmental vulnerability. In the second analysis, we used a discordant cousins design in which we had 2 cousins whose mothers had the same mother, and then one cousin was exposed to maternal depression and the other cousin was not. So in this analysis, we were also able to adjust for some unmeasured stable familial confounders. And then in our last analysis, we again used the full cohort and looked at maternal depression in 1-year intervals. So the results on our first analysis showed that children who were exposed to maternal depression had about a 17% higher risk of having a developmental vulnerability in one or more domain than children who were not exposed to maternal depression. And we saw that this relationship varied pretty substantially across the different domains of the different developmental domains, with physical health and well-being, social competence, and emotional maturity being affected the most. When we did the discordant cousins analysis, we saw that the relationship was stronger when we adjusted for those stable familial confounders. And so here we saw that a cousin who was exposed to maternal depression had about a 27% higher risk of developmental vulnerability on one or more domain than their cousin who was not exposed to maternal depression. And again, we saw that there was pretty substantial variation across the domains. And in this analysis, we saw that social competence and emotional maturity were affected the most. And then in our last analysis, we looked at the different exposure in specific intervals between birth and age 5. And here we saw that exposure So the dotted line is our overall measure, and then we see that exposure at any time had an effect on children. However, the degree of that effect was not that different, but we did see that exposure to maternal depression right before school entry seemed to have the largest effect. So in keeping with previous findings, we did see that children exposed to maternal depression were at greater risk of experiencing developmental vulnerability. But what this study added was that we saw that early childhood exposure to maternal depression was most strongly associated with vulnerabilities related to social competence and emotional maturity, and that exposure would have the strongest effects when children were exposed shortly before school entry. We did have some limitations that we need to keep in mind when thinking about the results of this study. We define maternal depression using claims, which is known to underestimate the true prevalence of depression. We don't know the onset of maternal depression, and so this could be particularly important for children exposed right after birth. So we don't know if that depression began after the birth of the child or whether that was ongoing depression that had been ongoing for a long period of time and was well managed. We also don't know, with the claims data, we can't determine the severity of depression, which could also impact the relationship. And we were limited in the confounders available in our data. So for example, things like parenting style, which could have a strong impact on this relationship, was not measured. We did, there is research showing that siblings have more similar parenting styles than non-siblings. And so in our discordant cousins analysis, some of that may have been accounted for, but not explicitly. And then we also don't have information on father's mental health, which could again be a strong factor on the outcomes of children's developmental or developmental vulnerability at school entry. So while this research answers some questions, it does lead to a lot more questions as well. So when thinking about what we want to look at in the future or how this research should progress is the need to examine underlying mechanisms. So focusing on aspects of caregiving and behaviors to which these children are exposed. And also to examine protective factors that may confer resilience to children exposed to maternal depression. And there's also other familial factors, such as having a sibling and whether that sibling has a developmental or mental health conditions and how that could affect the relationship between maternal depression and developmental difficulties in their offspring. So this paper was recently published in Pediatrics, so I'm happy to answer any questions, but there's also a lot more information available online. Thank you.
Thank you, Elizabeth. Lovely talk, and great that it's published, because all of us that we won't have time to ask all the questions we want to ask. We can look at the paper, so that's great. Okay, so I can see that we've now got 15 minutes for discussion, and we've got a number of questions coming up. So there's one each for the previous three talks, so I think we'll go to those first of all, and then come back to you, Elizabeth. So there's somebody's asking, Julian and Marni, do you plan to repeat the analysis in the future to see if the findings hold or change over time?
Sure, I'll start, and then Julianne, if you have anything to add, I welcome you to do that. We actually are in the process of repeating some of the analysis because one of the things that we've realized is this, as Julianne said, it's $81.41 a month that is this benefit, which is not huge. If you have an annual income of $9,000, it probably does make a difference, but it's been $81.41 a month since the program started in 2000. And we had the feeling that probably whatever effects the benefit we're having probably have decreased. And so we're currently running some analysis to see has the impact or the association with birth outcomes changed as the value of that has decreased over time. Julianne, anything else you want to add?
Well, I think that from my perspective, it would be you know, unless we actually have an intervention to change things, we might not want to suspect that there would be any change, right? If we haven't done anything, then there's not going to be any change, except maybe for the worse.
Can I just ask, I mean, this is a very quantitative conference, but I can imagine many of our colleagues in social science would be saying, you need some qualitative research here to kind of understand what was going on, what did people spend their money on, and what was going on in those families where they weren't claiming. Do you have any insights into that?
Yeah, and I can speak to that too. This study we've done a number of studies on the healthy baby prenatal benefit. This one focused specifically on Métis women and their children. Originally, we did one looking at the whole population of Manitoba, or the whole low-income population of Manitoba. We didn't focus specifically on Métis, or we didn't focus specifically on First Nations, just low-income women, period. And we did do a qualitative analysis of that. And, you know, kind of like we suspected, women did say they were spending the money on more nutritious food, but they also said that the money helped to reduce stress because, you know, some of them were having trouble making rent. The money helped them to really plan and focus on getting ready for babies. So they talked about buying things like diapers. And there was also this piece of trust, you know, that they were given the money to spend how they felt was important. You know, we can't measure how much of a difference that made, but it was reported by women as being important.
Thank you. Okay, so we're going to go to Emma Gordon, who's got a question for Louis, which is, did you look at the potential bias created within the sample on the data on children that you were able to link versus the records that you weren't able to link? Louis?
Yeah, so we've not formally studied that, so to speak. We have thought about it, and the reason we've not got round to that yet is because it's actually the data set we're working with is it's frighteningly difficult to actually know sort of how sort of non-response takes form. For one case, we have a variety of different types of data set. Some of those, particularly the health visitors data sets, have different kinds of unit non-response. So some are based on when the child was born, whereas others, I think, which is what Emma was hinting at, maybe visits that should have taken place but didn't, and they could be for a variety of reasons. So we certainly thought about it, but as I touched on when talking about imputation, it is remarkably difficult to actually know what sort of assumptions you should be making when you're thinking about that potential bias, and you can only really conduct analysis on what you know and give kind of hints at limitations and potential sources of that bias in your conclusions. To kind of tack on from that as well, there was also a non-negligible amount of unit non-response among.
Whoops, I think we're losing you, Louis. Louis, we didn't hear that last bit. Did you? Are you still there? I think you're muted now. Louis, you're muted.
Sorry. Was there a further point to that question?
We just missed the last bit. You were cut out for some reason.
I'm so sorry. Yeah. Yeah. I think that last point there was just I was talking about there were more than one potential form of non-response, and some of that was indeed unit non-response as well as item non-response. So it really just compounded the problem further.
I had a question for you as well. So could you look at the maternal trajectory of BMI as a predictor on it? Because you were really focusing on the child, weren't you? And I just wondered if you'd get better predictors from taking
the maternal BMI was something we did have information on. However, it did have a fairly large amount of missing data, and it's unclear when you should be measuring that, because people's lifestyles change obviously we're looking at a child from birth to 5 years old. It's unclear when you should measure that, whether there's any changes between those 2 points in time.
Okay, thank you. Okay, we're getting more questions now. Let's see. We've done Louis. There was one for Astrid. How do you follow compliance with prescriptions? Individuals can often refuse or hide the fact that they're not following prescribed meds.
Yeah, that's a great question. And again, with administrative data, it's very hard to do that. Certainly, I mean, and I think this is more probably related to opioid maintenance therapy rather than prescription, other prescription opioids. But we have done some other work looking at, continuous prescriptions, which are continuous filling of prescriptions, which makes that, makes the compliance more likely.
Great, thank you. And one for Elizabeth. On the subject of your work, raising further questions to answer, are you planning to look at other maternal mental illnesses and child developmental outcomes? So you just looked at depression. There's a lot of other maternal mental illnesses.
That's true, yeah. So right now we don't have a specific plan to look at other mental illnesses, but that's definitely an area that we could explore in the future.
Yeah, I wanted to ask you about that as well, and whether you were able to look at things like domestic violence or, self-harm, drug and alcohol misuse, as it's often correlated with.
Yeah, those are much more difficult to look at in our data. And so, and are like, when we do have measures of them, they really do underestimate the true prevalence even more than things like depression, which is underestimated, but not to the same degree as some of those other outcomes that you were mentioning.
Okay, so there's one here which is, for all of you, do the presenters feel that their findings have been used to steer social policy? Any examples from the past or current studies? Maybe we should go to Marni and Julianne first. I think you're the queens of research informing policy from Manitoba.
Julianne, do you want to start, or do you want?
Well, I'd like to think that we could, look within ourselves at the Federation to see who in our organization might be well placed to be. Well, for example, we saw in the numbers that almost 1,200 of these women didn't complete an application. And so is there somebody in our organization that could be identifying women that are pregnant and, steering them into completing that? For some, it might be that they don't have a social insurance number, or they've never filed an income tax claim or whatever. We now have an early learning and childcare program. So I'm hopeful that, at least when people are bringing their kids to that might be a point of contact. So down the road, I'm hopeful, but at the moment, we haven't made any changes policy-wise within our organization. And I don't see that our present provincial government would be doing that.
Hard to see from the participants who's here, but probably no one from our provincial government, right? One thing I can say is from the original study, when it came out, the provincial government actually did contact primary care providers who were seeing women during pregnancy, and told them about the Healthy Baby Prenatal Benefit, and encouraged them to tell their patients about it. So that was a good thing that came out of it. What we'd like the government is to increase the benefit, but so far that hasn't happened. So we'll see in future.
And Astrid, is your work impacting on policy at all?
So in terms of the prenatal opioid work, I would say we're doing a lot of associated work, and actually doing some work directly with some First Nations communities, and some of the data, just really even just the descriptive data on the extent of the problem, is being used on their part for advocacy for addiction services. So So not high level policies at all. And I would say, ironically, the whole area of the attention to at least neonatal abstinence syndrome was actually driven more by hospital bed supply initially, because the infants have to stay in the hospital to be treated when they were born. And that really was what was brought to people's attention, as opposed to the sort of larger issue of, what kind of services do pregnant women need to treat their addiction. So I would say it's sort of slow going on the more fundamental change that needs to happen to address the problem.
I was wondering whether you're able to glean anything for clinical practice, because the data you have on prescribing opioids in pregnancy must be timed. So maybe you can tell us something about, is it just late in pregnancy when we might see symptoms of NAS or of withdrawal in the baby, or is it throughout pregnancy? Does it tell us something about the timing of opioids that matter?
Yeah, potentially. The problem is the illicit use is really hard to quantify, and even in those who have prescription, we know this from other studies. So of people who die of overdoses, when they, we know what prescriptions they had, but then when they actually do the clinical pharmacology, there are other illicit opioids in their system, and so that's the biggest problem with that. So we haven't done some of that work, but it's true. It would be a good, there might be good things to do. Yeah.
So I think we've not got that many more questions. Louis, we are facing very similar challenges. Any attempt on harmonizing the data sets from Anonymous? Well, I think Anonymous needs to make themselves known to Louis, maybe offline, so that you could work on some harmonizing. Louis, do you want to respond?
Yeah, I mean, to be honest, I think most people would have had similar problems at some point in their lives with this sort of big linked data set. And to be honest, there's no real right answer beyond you have the information you have, and you don't have the information you don't have. And beyond that, you can only link the data with what you have available. And you can't magic data out of nowhere. But it would have to be a more specific inquiry into the nature of their data set.
Yeah. And another question from Emma Gordon, which is, Julian and Marni, you said you wouldn't repeat your study unless it was to evaluate a change. Do you see value in doing this in response to the COVID-19 pandemic? If this community has been hard hit, well, we were hearing just before we came on, Emma, that it is quite hard hit. So Marni and Julian, do you want to answer that one?
So is the question, are we planning to redo the study based on the current COVID pandemic and the impact it might have on our population?
Yeah, I think that's what Emma's meaning, that that would you repeat your study in response to the COVID pandemic, so that there's going to be a lot more hardship during COVID. I presume that's what's been referred to. And so you may detect different or more marked effects. I don't know. Emma, you have to type if I've got that completely wrong.
Might be difficult to tease that apart from what I had mentioned earlier about the decreasing value of the benefits over time. There's always these challenges with the kind of research we do, right? To tease out the different effects.
Yeah.
So COVID might be a little tricky with this one.
Yeah.
Marni, sorry. Can I ask Marni and Juliana a question? What about in the context of the Canada child benefit? Because some of them, at least not the PRIMEPs, would be eligible for those.
Yeah, we would love to be able to do an evaluation of the Canada child benefit, and you could do something similar to Healthy Baby, as you say, not for PRIMEPs, but those who this is a second or third. But unfortunately, the federal government has yet to agree to give us the data about who's getting the benefit, because although everybody's eligible, unless you submit your income tax, you don't get it. But yeah, Astrid, I'd love to work with you to work on getting those data from the feds.
There we are. We're doing that, people.
I was going to say that actually, you know, our participants or our sample might be faring better through the COVID because the Federation, our government, has done hampers on a fairly regular basis to vulnerable families. And so bringing them food and wild food, you know, are on the land food. So they might actually be better off nutritionally during the COVID than they were before.
Right. Oh, that's interesting. And do you have any insights into the mechanism? I mean, I just think it's really interesting. You've seen an effect on preterm birth and on large for dates. What do you think's going on there in terms of mechanisms?
I would hope that the preterm birth is because, you know, better nutrition, less stress, but we can't really tell. The large for gestational age is a little trickier. We're not the first to find this. The Canada Prenatal Nutrition Program, although they don't give cash to women, they give food or coupons for food. But they've found similar results, that there's been increases in large for gestational age. And, you know, whether that's due to weight gain during pregnancy, you know, I don't know, I'd look to the pediatricians in the group.
Is gestational diabetes going up? Is that what, I mean, are you able to look at that?
Well, we wondered about that. I mean, for this study particularly, we do know from other work that Julianne's been involved in that gestational diabetes is, Métis women are at greater risk of gestational diabetes, but there's nothing really, I can't figure out why the healthy baby would make that more so, receiving the benefit as opposed to not receiving the benefit.
Yeah. Okay. Well, I think we've had a good discussion, and I can't see any more questions coming through. So I think it's over to me to say thank you to all our speakers. I think we've had a great set of talks, and there's lots more work to be done to look out for from your endeavours. So thank you. And I have to tell the audience that do go and look at any of the on-demand posters and talks that are related to this. So thank you for all parts of the globe, and have a good evening, morning, wherever you are. Okay, goodbye.
Thanks, Ruth.